Welcome back, friends. So, this is the second part of our extra Levator abdominoperineal section, that is ELAPE versus APR, what to choose and how to choose. And we'll carry forward the discussion from first part onward. That is, in this part, we are going to talk about preoperative planning, the surgical techniques, and the prone versus supine position. So, friends, recently what we have noticed that they are teaching in rectal cancer, specifically the lower rectal cancer, the whole limelight has shifted on the LAR, total mesorectal excision, and the APR or this abdominoperineal excision has taken a back seat. So, friends, whenever we are planning the pre-operative assessment of a rectal cancer patient, specifically the low rectal cancer patient, that is the lower 5 centimeter of the tumor, it is always desirable in the NCCN panel that we should get the CCT abdomen and chest and MRI of the pelvis. So basically the CT is not a proper or adequate cross-sectional imaging for the rectal cancer, especially the lower third, and the MRI pelvis is must. And to have a basically the literature backup, you can go through this article published in BMJ by the Mercury Study Group. And so in this trial, they analyzed 408 consecutive patients from 11 European centers. And the aim was to have a correlation between MRI, basically the preoperative MRI for the prediction of curative surgery and final margin status. So, like they predicted whether the margin will be close or positive in the preoperative MRI, and then they later correlated it with the final histopathological examination, and tumor less than equal to 1 millimeter from the mesorectal fascia. Then the circumferential resection margin was potentially considered affected or the involved. So, in this landmark paper from Mercury Group, they concluded that preoperative MRI has a 91% accuracy in predicting a negative circumferential resection margin (CRM) in upfront surgery, and the accuracy was 77% only in case of neoadjuvant treatment, though it's quite good or very high. And the specificity of prediction of a clear margin by MRI is 92%. So out of this cohort, 327/354, they were able to predict clearly and with the confidence interval limit of 90 to 95%. So in this trial, they also recommended that for any rectal cancer patient, there should be a multi-department team approach or the tumor board approach involving the surgeon, radiologist, oncologist, pathologist, and nurses, aided by administrative and supportive worker from hospital to have a better patient outcome and for a better patient planning. So this picture is from the same paper, and on the right side of the screen is the MRI picture, and the left side is the level of tumor at the same level as the MRI. So in this picture, you can appreciate that the tumor has been outlined in a white and the mesorectal envelope is outlined in a red line, and there is a arrow indicating that tumor is just reaching or it is almost averting the CRM. And same we can appreciate on the left side of the picture, that is the final this tissue margins, that it is close margin. So this is how the MRI can be helpful. Having said so means every patient of the CA rectum should have MRI pelvis, and this should be discussed in case of a tumor board or multi-department meeting. And like in this case, the planning should be or should have been the APR, and we should have gone wider so that we can achieve a wider resection margins. Coming to the surgical technique per se, so in case of APR, like we continue our dissection from above downwards, and the TME that we stay in the plane of total mesorectal excision. So we continue our dissection, and as we approach the pelvis, that is the pelvis and the pelvic floor. The pelvic floor is formed by the levators. So as depicted in the red line, so we then start coning inside along the pelvic floor, or that is the levator. And as we approach near the rectum and the external sphincter complex, then we take out our dissection plane outwards and take out this whole chunk of the tissue. So the disadvantage of the This classical APR technique is that there is a hourglass type of waste formation at the left of the pelvic floor, and this is the final specimen on the left side. So there is a narrowing at the left of pelvic floor, and if the tumor is located somewhere here close, so there can be a potential involvement of the circumferential section margins. So intersphinctic APR is another variation. And so friends, just understand that when we are considering intersphinctic APR, then there is no tumor which is threatening the levators, and this patient is a potentially candidate for low anterior section where we can achieve the bowel continuity, but that is not possible because of the some comorbidity or patient is having pre-existing baseline incontinence. So there is no point of anastomosing, doing a ultra low or coloanal anastomosis, and so we simply cone and go between the two sphincters, that is the internal and external sphincter as outlined in this blue line, and then we take out this. Though the potential advantage will be that there is a lesser, smaller this perineal defect, and patient will have a lesser morbidity in the postoperative period. So the other option in this case, when we have a clear lower margin and tumor is high and is not threatening, then we can simply do the Hartmann also in this situation. The surgical technique of extra-levator abdominal perineal excision is then when we approach the pelvis, the pelvic floor, when we hit the levators, so then we are not coning it like in the APR, and we are simply taking out this whole bundle or the whole cylinder of the tissue as a bunch, and we come along the internus muscle, that obturator internus muscle fascia, and we take out the whole this levators and staying outside the external anal sphincter complex. So the advantage is when the tumor is close to the floor or the levators, then it will have a higher chance of achieving negative circumferential section margin as depicted in the blue line in this picture. So when we are dissecting from below, so we follow the margin of the sphincter complex, that is the external sphincter complex, in direction of coccyx posteriorly, and then dissection proceeds through the endococcygeal ligament and distal baldus fascia into the pelvis. Ischioanal dissection we have already covered before also. So it is one variant of ELAPE when the tumor is perforating or visualizing, or there's an abscess formation into ischioanal fossa. So we take out the whole pad of fat. So there are two pictures here. On the right side is the ischioanal dissection and the left side is the ELAPE. So in the ELAPE we are coming along the outer surface of the levators and the external sphincter. But in case of ischioanal dissection, we are taking out this whole fat, and this will be the largest defect which will be there in perineum, and there will be a requirement of closure with some kind of prosthesis. So if the other possibilities, like you can do ELAPE on one side and the ischioanal dissection on one side if it is involving only on the one side to reduce the defect size. And in case of ELAPE, it is essential that while we are dissecting from above, we don't start coning in when we approach the pelvic floor, and we just stop at the upper border of coccyx posteriorly and just below the level of minor vesicles or cervix anteriorly. Then we start going vertically downwards and we take out the pelvic floor. I hope you are remembering the final specimen in case of APR. There was a waste formation hourglass configuration, and this is the final specimen from a case of ELAPE, and as student can appreciate, there is no coning in, and if there is tumor around this part of the rectum, around the pelvic floor or where levators get inserted, then the possibility of achieving negative CRM is higher. So friends, for abdominal perineal excision, be it APR or ELAPE, then the which position we should choose. So in a lithotomy position, there is a poor visualization of the anatomy, and there are higher chances of perforation of specimen and positive resection margin, and the relevant literature support I have given here, and viewers can go through these papers. And in prone position, the vagina, the prostate, autonomic nerves are easier to see, and there is a better control of the procedure. So the recommended position for the abdominal perineal excision, specifically the ELAPE, is prone position. So, friends, this is a paper by Sir Heel Group, who are the pioneers, and so they studied the undertake this study to test the efficacy of extreme policy of sphincter conservation. That we should try to conserve the sphincter in case of a low rectal cancer as far as possible. So, tumor less than 5 cm from the anal verge were considered. So, 136 patients were there, out of which 31 underwent abdominal perineal excision or the APR. So, in anterior section group, they saw the recurrence rate after 6 years. In the curative group, when the resection margin was negative, was one case, and when the resection margin was positive, that's non-curative, it was 3 and total 4. That was 4% only. And after abdominal perineal excision, the recurrence rate in curative group was 4 out of 15 and 5 out of 16, and total 9, and so 29% had a recurrence after abdominal perineal excisions. So does that mean that we should always consider the anterior section, or the other side of story of this paper? I mean, that is my personal interpretation, that these surgeons can basically persist for the sphincter preservation beyond the limits, and they always try to do a lesser surgery to avoid the comorbidity. There's a lesser exposure, and so despite doing the abdominal perineal excision, these patients had a higher recurrence. I mean, that is not something which should have happened when we are doing such a extensive surgery. Then why there should be a recurrence? So I mean that you can analyze the paper at your end also. So, but my take is that we are not giving the trainees the adequate exposure, and we are trying to cone in, resulting in a higher positive CRM and higher recurrence rate. Here onwards, that is the different trial, color 2 trial, its relevance. We will discuss in part 3 of this series. So thank you very much, viewers. I hope we were able to add some new tips and some new insight to your knowledge. Thank you very much. Happy learning. Stay tuned.